Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
Hi. James, let's start as always with our quick fire questions. But actually, I should probably think of some because I have no idea. Okay, let's talk about favorite exercise these days. I know you're currently injured, but are you loving the CrossFit, cycling? What's your favorite mode of exercise?
More easily list things I don't like. I don't like running. I like doing strength training. And before I was injured, the thing I was really enjoying actually at CrossFit was learning how to do gymnastics. So trying to do muscle ups and things like that because It's difficult and it's punishing actually, but you can feel like you're making progress. So yeah, that's today's answer.
Maybe the next quick question is a follow-up. How did you injure yourself? The G-rated version.
Yeah, what does G-rated mean?
Oh, this is a U.S. Motion Picture Academy rating on movies. So this would be
suitable for
appropriate
family viewers.
Family appropriate.
Oh no, there isn't a good story really. I was actually it's CrossFit Open, which is an annual competition open to anyone in the world. There's like 300,000 people that go into it, all shapes and sizes, all levels of fitness. It's sort of a institution. So I was doing that. And it's 3 weekends in February or March. And the final weekend had a lot of pull-ups, basically. I don't know how many there were altogether. Chest to bar pull-ups, so they're more difficult than regular ones. So I did that. And then at the gym on the Monday afterwards, 36 hours later, there was another massive load of pull-ups. And so I ended up doing about 100 pull-ups in 36 hours, which, at my age, it's not good, I don't think. And I often have twinges in my elbow, but then after that, I just have persistent pain and I've got tendonitis, I think, which usually takes months to get better. So but injury, part of life as far as I'm concerned. And, it'd be strange if you didn't have some at least ache or pain or niggle. To me, it means you're not exercising enough. But anyway.
From your mouth to everyone's ears. Okay, what'd you eat for dinner last night?
Oh, I can't even remember. It's some really quick pasta thing, actually. So nothing, yeah. So we try and avoid too much carbs, actually. But we just kind of, threw in the towel last night and had some pasta. So that's quite boring.
All fine. Well, let's continue our adjuvant therapy discussions. Keynote 054, also known as EORTC 1325, but more colloquially, I think, called Keynote 054. Tell us about this study. You're a co-author on this study.
Yeah, it's an important study. Basically, adjuvant Pembro for a year versus placebo. Stage 3A, stage 3B, stage 3C melanoma. And in many ways, I think analogous with Checkmate 238. I think that's really the comparison. And maybe the things to pick out as differences would be that Checkmate 238 had some stage 4 NED patients in it, as we discussed in our Checkmate 238 podcast. And then Checkmate 238 didn't have 3A in it as well. And then the other, maybe most important bit of all, is there was the opportunity, if you receive placebo treatment in the trial and then you subsequently relapse, to get anti-PD-1 monotherapy with Pembro at the point of relapse, which speaks to this whole big question, not just in melanoma, but across cancer, about now or later. So I'm sure we'll come back to that.
Yeah, so tell us the very top line results of this study, primary endpoint results.
Yeah, so the top line is significant RFS benefit in comparison with placebo, which I think is what you would have anticipated. You're probably looking up the figures now, but I think 0.5.6 type of range for hazard ratio. So very clear difference. Early separation of the curves, maintained separation of the curves, and toxicity as you would expect from a year of adjuvant anti-PD-1, which maybe we don't need to labour too much in and of itself. But I think, there's lots of adjuvant studies now in multiple tumour types of a year of anti-PD-1. And I think, people sometimes talk about the tox at length. And for me, it's like, okay, this is what we're expecting. The interesting thing, of course, is there's things you're not expecting. But I think by then, we got pretty used to using anti-PD-1s, actually.
Right. So what do you think is not expected in this adjuvant setting with anti-PD-1 therapy?
Well, I suppose what I would be thinking about, let's say, is if you saw a lot of pneumonitis or something like that, or a lot of
Yeah.
nephritis or something. So I think this trial showed us. But,
Yeah.
you maybe look at other diseases, for example,
Right.
and then you see more pneumonitis maybe in a lung cancer trial. I wonder in kidney cancer, if we've seen a bit more nephritis in the adjuvant setting than you would have predicted. I mean, it's difficult to say because it's a rare side effect. And then it's a little difficult, I mean, just to quickly talk about that, in kidney cancer to say, well, are the patients really getting more nephritis than you'd expect? And if so, why? Is it because they've only got one kidney, they're vascular paths, but that doesn't, that's vascular disease. It's not predisposition to nephritis, but maybe there's low-grade inflammation. I don't know. You could just make it up, really, couldn't you?
Yeah. So tell us about crossover design, when we might see the first signs of that. This is a placebo-controlled study, so theoretically you don't know what your patient gets until there's a recurrence, and then you unblind and then see about crossing over. There's also retreatment, right? If you were on the Pembro arm, you could get retreatment so long as you didn't have one of these kind of major side effects during the course of treatment.
Yeah. So that happened during the course of the trial. We did this with our patients, and I think it was mainly reported out on, I think, the 5-year mark. I remember Lex Egermont actually presenting it at a meeting and publishing it. And there haven't been that many events, actually, was going to be my first comment here. And I personally found it quite difficult to interpret this. And I think it would be great if there was a clean answer to the now or later question. But the problem is, in real life, it's just never clean, obviously. And it might be you have someone who relapses, and actually you don't want to give them single agent anti-PD-1. You want to give them some other treatment. You might want to give them ipi/nivo. They might have brain mets. There's all sorts of other things. So I think the idea of being constrained, if you like, in how you treat someone at relapse is inevitable and just a problem with trial design. So I think
am I hearing a bit of cynicism that we won't get this answer? We won't get an answer that we can comfortably interpret because we will pull patients off at recurrence and give them combination because they won't recur at the rates that are, expected, et cetera, et cetera?
Yeah, I think cynicism's a bit too strong.
Okay.
But I might say pragmatism.
Okay.
And I've said this in public. I mean, I think I said this a couple of years ago. I mean, again, I treat kidney cancer. And so in the last few years, there's been lots of discussion of adjuvant treatment in kidney cancer. And of course, I'm kind of colored by the melanoma experience. And, interestingly enough, in the kidney cancer world, there's significant resistance in certain quarters to giving adjuvant pembrolizumab, even though there is a trial now published with an overall survival benefit. And some of the arguments are, well, not all the patients need treatment. But I mean, frankly, I think that's a trivial argument because part of the definition of adjuvant treatment is that you're treating people who may not need treatment. So I would discard that. But and so I'd say this, and I say, well, look, this whole business of now or later, it would be great if you could design a clean trial to really look at it, but I don't think it's possible ethically, honestly. And also, you think about the event rate and the event numbers and the amount of follow-up that you would need to do, never mind the issue of changing standards of care over time. Personally, I don't think it's tractable, and I don't think we're going to see that. We just have to try and kind of deal with what we've got at the moment. So I think it was a great attempt, actually, in the trial to get a bit of traction on this issue, but I personally don't find the data that easy to interpret, honestly.
I think you're right. I think that's kind of the consensus. We would love to see this, but that's loving to see it in a bubble. Once we see it, we will start to wonder, well, why didn't people get ipi/nivo in the frontline metastatic setting? And, what if? So let's talk briefly about toxicity. This study has been published in multiple venues. It was originally published in New England Journal of Medicine. There was a Lancet publication. There was a New England Journal of Medicine Evidence online publication. So there's a lot of versions of this, but in one of the publications, and I believe it's the Lancet one, because this is the one I like to share with fellows, there's an interesting table in there that essentially describes toxicity and the occurrence of toxicity and how certain patient populations might have actually maintained a benefit in terms of hazard ratio by receiving the adjuvant pembrolizumab, and other groups with high-grade toxicity that may have been all for naught. They may have lost any RFS benefit. So what is your take on toxicity, the development of it, how we manage it in this adjuvant setting?
Yeah, this is a complicated subject, and I think the metastatic experience is relevant to this as well. If someone's got side effects, they need to be managed safely. I think that has to be number one, for anyone that's listening. The next question is going to be, well, does immunosuppression for the management of side effects blunt the efficacy of checkpoint inhibitors? This is a big question for me, actually. And if you look at the guidelines for toxicity management, certainly the ESMO ones, for example, that I'm involved in, very early on, it says we need to use the minimum amount of immunosuppression to manage side effects. I think that's really important, really, really important. And I still see patients, being referred and so on and so forth, who, in my view, have been far too heavily immunosuppressed. And it's almost worth a podcast in its own right. But I think the tension there in the system is that you do need to manage side effects safely. But if you're not experienced at managing side effects, you're going to tend to err on the side of caution, which is to use more immunosuppression, so higher doses of steroids for longer. And there really are some side effects where you have to use high doses of steroids. So neurological side effects are one example. Cardiac side effects are another one. Sometimes colitis if it's steroid sensitive, but it isn't always steroid sensitive. Mm-hmm. But, hepatitis, for example, you just don't need high doses of steroids in general. And you can run people, and I do this in clinic. I would run people as long as I've got control of their transaminitis. I'm not trying to make it normal. I'm just kind of controlling the toxicity using a minimum dose of steroids. So anyway, that's just a real kind of quick diatribe on that subject. So there is this big issue in there about whether the immunosuppression to manage side effects could be detrimental. So then just going in a little bit further, there's some side effects where we don't really use immunosuppression. The endocrine ones are the most obvious example of this. So in that group of patients, let's say, who develop endocrine side effects, nothing else, don't really get any steroids, could the development of the side effects be some sort of marker of sensitivity or dose? So there's a big issue in there as well about doses within people, as it were. And I'm sort of just putting it out there. And actually, those patients do best. In other words, they get side effects. They carry on with treatment, endocrine. They probably don't get immunosuppressed with steroids, so they're doing a lot better. So to me, that's still a hypothesis, right? And there's been a lot of discussion about this. And I still don't think we really have an answer to this. What I'd really like to do, just to finish off this point, and I haven't been able to do this successfully so far, although one of our ex-fellows is trying to do this at the moment, is in metastatic disease. I don't think you and I have discussed this before, do a randomized trial of conventional immunosuppression per guidelines, let's say, to manage side effects versus permissive light touch immunosuppression to manage side effects. And what I'm thinking here is, let's say, Ipi/Nivo induced hepatitis. It's quite a common side effect, okay? And then in the protocol, it would say that you randomized in the light touch arm, you have basically the very minimum amount of steroids in the kind of grade 2, low grade 3 type of ballpark. The bad side effects you obviously manage according to standard guidelines. I'm not disputing that for a sec. And then I would have a hard efficacy endpoint for that randomized trial with appropriate powering, because, I'd really love to see some prospective data. And in clinic, this is how I practice. And, it's just my anecdotal experience. It's not. But anyway, so Andreas Schmidt, one of our ex-fellows, now works in Basel in Switzerland, is trying to get funding from the Swiss Cancer Fund or Swiss Cancer Charity for doing that randomized trial. So that'd be great if Andreas can do an academic trial.
I love that. And actually, you said so much that I just want to pick up on. So I like the idea that there are some side effects that we don't manage with steroids. So, one of the classic markers we've always thought that was a marker of autoimmunity, as it were, was vitiligo, but we don't manage this with, steroids in general. And so that table in the Keynote 054 study will show patients who develop vitiligo might be having some benefit. Again, is that some sign of internal immune activation or not? But they don't touch steroids, therefore they don't have any sort of detrimental effect to that immune activation. So endocrinopathy is one of my biggest, I think, what's the right way to say this? Let's frame it as a teaching moment. When somebody comes in adrenally insufficient, yes, they might even be in a mild amount of crisis. They may be feeling poorly, hypotensive, all these things, but not hypotensive where you're using your intensive care unit and you're using vasopressors. They're hypotensive because they just don't have enough cortisol. They don't have enough steroids in them. And in these patients, I routinely see A&E centers, as you call them, our emergency rooms, the person on call over the phone using a high dose of steroids. That's not what they need. They need physiologic replacement. They just need you to refill the tank of what they would be giving themselves. This is not the moment that they need, stress dose steroids. If they were coming out of a surgery, if they were also infected, if, there are other reasons that stress dose steroids might be needed, but your run-of-the-mill hypothyroidism, adrenal insufficiency, they just need the hormone that's deficient replenished. They don't need stress dose. So that's the first teaching point. There's just no need to give, a gram of solumedrol to these adrenally insufficient patients because of what you might be doing to their immune surveillance. So that's, I think, a key point. And I often with the transaminitis, my teaching point is when that patient comes in after a gap of 2 or 3 weeks, because that was your interval from your last dosing, and we don't really have any guidelines that say we need to be checking our patients weekly. When your patient comes in and you have a grade 2 or a grade 3, like you were saying, kind of low grade, grade 3 transaminitis, my first question, because the instinct of everybody, all our practitioners who surround us, is to throw high dose steroids at that, 2 milligrams per kilogram or higher at that. My first question is, what is the trend of that transaminase? Do you know if it's on its way up or is it on its way down? It actually peaked last week, but we didn't check it. And now it's on its way down with no intervention. So my first thing is to do a short interval check of it in 48 hours, 72 hours. Not overreact, don't hospitalize, don't throw steroids at the problem. Just figure out what the trend is. Because if it's already on its way down, just keep your hands off. Just don't tap the brakes here. Just keep your hands off. Don't use any steroids. Don't intervene with their already, immune system activation. Now, if it's on its way up and you don't like the trajectory, of course, but me, very much like you, this is where I use 0.25 mg per kg, 0.5 mg per kg. I don't even see the need to use 1 or 2. I do that light touch, as you say. It's incredible how sensitive these enzymes can be to that.
Yeah, absolutely. I mean, which takes us back to tempo. It's exactly the same thing, but now we're talking about toxicity. And we're talking about the fact that the CTCA guidelines and others can't capture this because it's too complicated. That's not a criticism. But I don't reckon you've read our article, actually. So Andreas and I wrote a comment, just to do a bit of shameless self-promotion, in Lancet Oncology, I think, in the last year or two. It's easy. It's just a one-pager, actually, because I've been getting a bit obsessed about this. And, we talk about a test dose of steroids, basically. And actually, Lavinia Spain from Peter Mac, hi Lavinia, if you're listening, was a co-author. She was one of our fellows in the past as well. But it's exactly this: tempo, number 1, test dose of steroids, number 2. And with checkpoint inhibitor-induced hepatitis, that's almost always the right way to practice, actually.
Sure.
I think we're running out of time, actually, on this. I was just going to say one other thing maybe about Keynote 054, and then that's the 3A, basically. So there's a lot of talk about 3A. Do they quite need adjuvant treatment? I mean, my 2 observations there, I think, are that the hazard ratio actually for benefit looks pretty similar in 3A versus 3B versus 3C in terms of potential level of benefit from treatment. So the issue is about absolute risk. And so for me, I wouldn't say there's right or wrong here. I think you've got a patient in front of you in clinic. You obviously need to know if they've got a BRAF mutation or not. I think that's highly relevant here. If they don't, then you need to be really clear if you're thinking about giving adjuvant treatment there, what the benefit is on the upside. It often might not be that big in absolute terms because they're getting exactly the same downside, those patients, as the ones with 3C or even stage 4 NED if we're talking about checkmate 238 and Nivo. So when people have black and white views on this, I just think that's a bit too strong.
Yeah, fair point. Very fair point. So well said. Keynote 054 then, adjuvant Pembro versus placebo. Crossover will be challenging to interpret a now versus later question just because of the world in which we practice now. But there clearly is a benefit in resected stage 3A to 3C melanoma. What else? Anything else we need to say about this?
No, nothing I can think of. Thank you.
All right. Thanks, James.